of the larynx. Malignant neoplasms, sometimes it's like this picture. We're looking for one thing, but the clue may be something else. So here's an old city, but there's something new going on. And it's sort of like that in the larynx. We may see some traditional changes, but there are some new things to understand. The squamous lesions, most of these have precursors, and that's usually a dysplasia. Many of these will progress to cancer, not all. And these are usually supraglottic and glottic, so not infraglottic. Tobacco and alcohol, of course, are the prime risk factors and of concern. Microscopically, we can see, again, this very long continuum of low-grade to high-grade dysplastic changes. And that can be associated with thickness of the mucosa, cellularity, with nuclear changes, crowding, lack of polarity, and so forth. And the other things that we think of for dysplasia: increased nucleus to cytoplasm ratio, increased nuclear size, and so forth. And of course, we don't see basement membrane invasion. So I have 6 cases for you to quiz yourself on, okay? Low, medium, high. Those are your choices, or no dysplasia. So I want you to write these down. What do you think your grade is here? Is this low grade dysplasia, moderate dysplasia, severe dysplasia? No. Write your answer, okay? We're going to have 6 cases. So 1, 2, 3, 4, 5, 6. Write 1, low grade, medium, whatever. Okay?
Low grade.
Okay, so one person's voting low grade. Anybody else? Okay, how about this one? So some low grade, some medium. So
medium grade.
Medium grade. Okay. How about this one?
High grade.
High grade, yeah. Those atypical mitoses help. How about this one? Moderate. Say moderate. How about this one?
Low grade.
Low grade. Perikeratosis, dyskeratosis. Low grade. And how about this one? High grade. Okay, so I'm very proud of you. You all identified the high grades correctly. But I showed you these others to illustrate that differentiating low from medium can be very difficult because they're all over the map. And if we look at what the publisher of these pictures called them, number 1 was moderate dysplasia. Most of you wanted to call that low-grade dysplasia. I think you got most of the others correct. But the point of this is that dysplasias are not highly reproducible. We aren't all going to achieve total consensus with what somebody else says. And so grading dysplasias is a challenge for pathologists' consensus. And therefore, the management of dysplasias is also probably problematic. Right now, I think the management issue for dysplasia is pretty much the same. Low grade or high grade, they're going to follow that patient closely and try to remove or treat any lesion that they can identify. But understanding that what the clinical choices are may make a difference. So going on to squamous carcinoma in the larynx, again, this is tobacco and alcohol are the risk factors. and usually men because they're the ones who consume tobacco and alcohol. So with this, the prognosis is highly dependent on the stage and location, and the treatment is usually a combination of surgery and radiation. It's important to remember that because of this exposure, many times patients can have more than one tumor. They have a clinically identified tumor, there may be other sites as well. And this is where location becomes very critically important, because whether a tumor is a glottic tumor or supraglottic or infraglottic, as in this case, can make a big difference in the type of surgical approach and the fields of radiation that are chosen, and whether or not certain lymph node neck dissection areas are removed. So our job as pathologists is to make sure that we explicitly define the location of the tumor as best we can in terms of supraglottic, above here, glottic, or infraglottic. It's also important to specify whether it crosses the midline. So unilateral tumor, one treatment; crossing the midline, bilateral involvement, different treatment, different lymph node dissection, etc. So this is very, very important. So just to review, what's glottic? Well, glottic is essentially anything that involves the true vocal cord. Okay? Supraglottic, big space, everything from the true cord north. Infraglottic, everything below the true cord. Okay? This distinction is the critical one for treatment. You can find other terms here, transglottic and so forth, but these three terms are the ones you need to understand to communicate with your colleagues. Understanding the microscopic anatomy is also important because we realize that tumors, may dissect this direction. They usually have a hard time getting through this membrane. So if a tumor has transgressed between the thyroid and cricoid cartilages, that usually is advanced stage. Or if it has penetrated into the thyroid cartilage, again, that's an advancing stage. So understanding the depth of invasion and these structures is also important. So what about grading of laryngeal cancer? Should we grade squamous cancers of the larynx? Do we call it well differentiated or moderately differentiated? Well, for salivary carcinomas, grading helps. But for squamous carcinomas, the histologic grade doesn't make much difference in terms of patient outcome. It is recorded. We do report it on the CAP protocol, but in terms of clinical value, it doesn't differentiate behavior of the tumor. So we have a variety of variants of squamous carcinoma. We've talked about many of these. What's this? Verrucous type carcinoma. Very long papillae, not much of a granular layer, pushing lower border. Another type that is seen here that can look a little bit like verrucous is exophytic papillary and squamous carcinoma. This tends to have a better prognosis than usual squamous carcinoma, mostly because it's exophytic and it's discovered earlier at stage. and it doesn't have this highly aggressive invasive characteristic. To call it this, it needs to be at least 70% exophytic. And then these are usually broad, bulbous, rounded growths that have this pattern. So here's an example, a very broad papillary type pattern that we see here. Or another one, exophytic, broad squamous nests occurring, and not much identified invasion. So it sometimes can be hard to identify invasive cancer in this. Here's another example, long papillary fronds. Like in the oropharynx, it can sometimes have this inflammatory microabscess appearance. The cytology here, though, is malignant. It's not like verrucous carcinoma. You can tell this is cancer cytologically. The cells look bad. Here's what they look like. You can see they're disorganized. There's dyskeratosis. There's mitoses. It looks like cancer. Sarcomatoid carcinoma, we've talked about that. I won't go into that any further at this point, other than to say that sometimes you can get this lesion that can look a little bit like sarcomatoid squamous carcinoma. So if you have something that looks like sarcomatoid carcinoma, but it's not staining with keratin or something, you might think about doing an ALK1 to possibly consider inflammatory myofibroblastic tumor. Basaloid carcinoma is a very important entity to distinguish because of its behavior, frequently having associated metastasis at the time of identification. And there are several things to recognize with this. The basaloid cells with peripheral palisading, abrupt keratinization with small pearls, maybe even cometonecrosis, and a very high mitotic index. These have the usual carcinoma keratin positive features with CK56 and P63, and the differential diagnosis, as you see here, with neuroendocrine carcinomas and so forth. Microscopically, here's a nice example. Very basal appearing cells, a little bit of peripheral palisading, and this cometonecrosis. Here's the feature of abrupt keratinization that we talked about. Notice this is different than the midline nut carcinoma, which has a very well differentiated appearing area like this. With basaloid carcinoma, these keratinized areas are still malignant looking. They're still high-grade cancer. Another more uncommon tumor that we can see here is adenosquamous carcinoma with characteristic squamous areas, juxtaposed glandular areas, and a mucin stain will usually highlight this as well. Now you might think, well, is this just mucoepidermoid carcinoma and under a different name? And I think it's slightly different in that sense. It's not quite the same as mucoepidermoid carcinoma, which tends to have defined ring-type cells rather than these glandular formations juxtaposed, the squamous differentiation. This is a biphasic carcinoma. It may have some undifferentiated or transitional areas between them, but it can also be a variety of other patterns. So we have separate adenocarcinoma, squamous carcinoma. We have intermixed carcinoma or mixed up carcinoma or transition zones. These will usually also, again, stain differently in the different components. So immunohistochemistry can help us here if we have a question about glandular versus squamous differentiation. So the differential diagnosis for adenosquamous is basaloid squamous, mucoepidermoid or adenocarcinoma with squamous metaplasia, possibly necrotizing sialometaplasia if you have very atypical elements there. Okay. We'll go on to neuroendocrine carcinomas, which are quite rare in the larynx. However, it is the most common non-squamous cancer, so it's more common than adenocarcinoma, but it's not common. It's usually supraglottic, as this image indicates. It's up here where we have minor salivary glands and other sorts of lesions that have the precursor cells. We don't have salivary glands in the larynx, in the vocal cords, in the true cord. And so you would not have a neuroendocrine carcinoma arising there in that lesion, in most cases. Grade and stage usually make a difference, of course. And again, it's more men than women. It probably has a smoking relationship as well. Now, this is one situation where the trend, if you will, to separating and grading and so forth has not fully evolved in these areas as it has lower down in the GI tract. Most people would call this a neuroendocrine tumor. Would we all call it carcinoma now? I think there's beginning to be some trying to standardize the nomenclature for all neuroendocrine tumors. So I'm not sure everyone would call this a neuroendocrine carcinoma unless they had metastasis already. But suffice it to say, there are grades of neuroendocrine tumors in the larynx as there are elsewhere, and using your best guesstimate of that terminology is appropriate. Some of them will clearly be like small cell carcinoma, very high grade, undifferentiated, with a neuroendocrine flavor to them. These are clearly going to be carcinomas, but the more carcinoid-like lesions, should we call them carcinomas? I don't know yet. I don't think so. As far as reporting goes for laryngeal carcinomas, there is a CAP protocol, and this does include melanoma and neuroendocrine carcinomas. Now, I think in the future, the neuroendocrine lesions may get a separate protocol, but right now, it does include neuroendocrine carcinomas. Our colleagues down in Ho Chi Minh City are also working with us to translate these. So your work and their work together should make it possible for everybody in Vietnam to have access to these protocols.